Welcome everyone to today's webinar, How Steward Healthcare Prevented $16 million worth of inventory from expiration in 6 months. My name is Molly Gamble and I'll be your moderator today. On behalf of Becker's Healthcare, thank you for joining us. With that, I am pleased to welcome today's speakers. We have Michael Prokopis, he is the Senior Vice President Supply Chain for Steward Healthcare, and Carl Nattenstead, CEO of Z5 Inventory. Michael and Carl, thank you for being here today. Carl, I'll turn the floor over to you now.
Thank you, Molly, and thanks everyone for joining today's webinar. At this time, Michael, I'd like to ask you to give a little bit of a background on Steward Healthcare, please.
Glad to, Carl. Good morning, everyone, and welcome. Steward Healthcare, we are a privately held IDN. We have 34 facilities in the U.S., 6 international, 3 in Malta and 3 in Colombia, most recently. You know, the important part of who we are and maybe what differentiates us from others is that being privately held and for profit, but we also believe that we can deliver better quality health care in the communities we serve. So that's just a very short synopsis of who we are. And with that, Carl, back to you.
Thank you, Michael. A little background on Z5 Inventory. We are a software and services company founded in 2015, and we're focused on the purpose of helping hospitals and health systems to save money and eliminate expiration from their supply chain. And we do that by bringing 3 products to market, Count, Reallocation, and Z5 Buy. And we're excited to present to you kind of the results of our project with Steward Healthcare today. Now, Z5 estimates that as much as $5 billion worth of medical product expires on hospital shelves every year. And just today I read in Becker's an article that reported that hospital volumes in Q2 2020 were down on average 35% nationally. And that means that product expiration is only going to get worse in the upcoming years if we don't do something about it. So while all those cases were being averted and all of you were taking care of coronavirus patients, product is sitting on the shelf and the clock is ticking. Now, I'd like to kick off the webinar today with a quick polling question. Get a sense of how much inventory do you think could be excess in your hospitals? 0 to 5%, 5 to 15%, 15 to 25%, or more than 25%. Please take this opportunity to answer the polling question, and we'll reveal the results here in a moment. Again, what percentage of your current inventory do you think could be excess? 0 to 5%, 5 to 15%, 15 to 25%, or more than 25%? Okay, we have about 50 respondents, so let's take a look at the results so far. Interesting. So about 10% of you believe 0 to 5%. About 40% believe 5 to 15%. 35% believe 15 to 25%. And 15% of you believe you may have more than 25% of your inventory at risk for expiration. So interesting results. Michael, can you give us a little insight into what the reality was for Steward Healthcare?
Yeah, so you know, we did a physical inventory where Z5 helped us do the actual count. And when we were done with that, we had a conversation about what we thought the expectation was. And like many of you, I would have said probably maybe 10 to 15% would have been kind of the number that I was thinking about. The reality was close to 30% of our inventory was in fact excess. And excess can be measured in a lot of different ways, but the way we chose to do it here was specifically around, let's look at the last 12 months of PO purchase history, and then, you know, because that will then indicate, you know, potentially what was being consumed, and if you project that out into your next year, what's left over. And so, surprisingly, we found a large amount of inventory quite frankly, sitting on the shelf that wasn't turning at the rate we would have expected it to. The other part of it is that to think about it in terms of spend, which is, how much of your spend is sitting on the shelf. And in our case, we're on the higher end of that 1 to 3%. But here's the more important question to ask yourself. If I didn't spend it on inventory, what else could I have spent it on? Whether it was to fund the next capital project or maybe even to do something specifically for employee engagement or enhancement. So there's a lot of different ways we can spend money, but the question really becomes, how are we spending it? And there's certain things we have to spend money on, and we convince ourselves that inventory is one of them, and of course it is. That's how we make sure that we have what's needed for a procedure on the shelf. But the reality is if we're not doing it smartly, then quite frankly we're accumulating as much as we are consuming.
Now, excess and obsolete inventory is a challenge for almost any industry, and healthcare is no different. There are some unique factors, I believe, in healthcare that really lead to and cause products to become excess and obsolete in the hospital sector. And so some of those we've got here, and maybe Michael could give us a little bit of how these played out relative to Steward as well.
Yeah, reason number one, especially after coming off a pandemic, will resonate, I think, with the entire audience, which is the fear of shortages. We all watch TV and we saw the hospital in New York or the hospital wherever it had, Chicago, and they were wearing trash bags or whatever else it was, and there you are sitting there saying, not at my facilities. And so whether it's PPE in a pandemic that you're trying to source, or we know things go on back order all the time. In fact, I argue with our distributor all the time that their fill rate, which they claim is at 98%, isn't what the hospitals fill, because quite frankly, they back out all of the back orders. And the back orders are really, at the end of the day, a lot of what people think about when they're thinking about their experience with inventory. And so, people hoard. That's just a natural tendency to do that. Last time I tried to get this, it was hard to get, and so I'm going to make sure I have 3 extra sitting on the shelf, or I'm not going to be the one that has trash bags on our clinicians, and so I'm going to make sure I've got 1 million stockpiled someplace. And those are all I think reasonable outcomes. But at the end of the day, if we allow that fear to take hold, it can lead us into some very bad habits. Second is around the advancement of technology. Who doesn't want to try the latest and greatest? And in fact, recently had a conversation with a surgeon out west who said, I helped that company, invent that thing, and this is all the clinical benefits that it's going to do for us. And so now we have to use it. And so you start using it, but you may use it in context or in replacement of other things that were already there. And that causes a problem, especially in situations where you might have done some bulk buying, anticipating future demand. And kind of correlated and related to that is, we buy things all the time for physicians who are with us, and then, their contract ends and they go someplace else, or maybe even in some cases we've asked them to leave. But the point is that we set up a whole buying pattern and system to support their caseload, their preference cards, and then the reality is something causes that to change. And oftentimes it can just be the advancement of technology. And then the final one, which, if you're at a high compliance GPO, it really will force you into some bad habits, because there's the concept of sole source all the time. And we all know that getting to 80% compliant leads to better volume discounts and better rebates and better price points. And so, we're always looking for ways to save our systems money. And so we quite frankly chase some of those contract changes. But it can also lead to obsolete inventory that's sitting on the shelf if you're not actually planning those conversions correctly and allowing them enough time to draw down potentially the excess inventory. So, all of those things together are, so it's not easy to say, here's the one thing you do and that solves all your problem. It's kind of a myriad of different things that impact our ability to buy inventory and keep it on the shelf.
I think all of those were in play at Steward Healthcare, and our experience at Z5 is that all of the health systems around the country are experiencing these various causes in one degree or another. And the mixture of those leads to quite a buildup of excess and obsolete inventory. And as Michael mentioned, the analysis at Steward, which was performed, initially revealed that as much as $24 million of inventory might qualify for reallocation. And as Michael indicated, that kind of rule of thumb that we use to identify a specific SKU for possible reallocation was something that had not been purchased in the last 12 months. Now, with the influx of the pandemic and the dramatic changes that we're seeing in healthcare practice patterns throughout our health system customers, we're now doing some auxiliary analyses to possibly look back an additional 12 months and say, well, in a normal year under normal caseloads, would this product have been consumed? So we've made some adjustments to our algorithms to just take effect of the pandemic. But nonetheless, the challenge is still there, and the initial inventory identified at Steward Healthcare was $24 million. Now, deepening the analysis, one has to ask themselves, okay, I have $24 million worth of identified excess and obsolete inventory. What can I do with it to maximize the monetization of that? How can I get the most value back for Steward Healthcare? And with Z5's help, we were able to run over 100 different AI-driven analyses and attempt to identify the best outcome for each SKU of inventory. And in many cases, that might be as simple as moving it from one Steward facility, perhaps in Boston, Massachusetts, to another Steward facility down in Beaumont, Texas, and that product would get used. In other cases, the product had no usage throughout the Steward facility group and would need to be sold into the secondary markets, and Z5 provided a mechanism for doing that. And then last but not least, there's always some amount of product, perhaps a couple of technology cycles old, that nobody's using either at Steward or in most of the industry, at least here domestically, and perhaps that inventory could be donated. And as you can imagine, the scope of this work is large. At Steward, it encompassed 36 facilities, looked at over 365,000 different SKUs, thousands and thousands of lines, and ultimately we were moving over 10,000 totes. So the scope of the effort is large and the project is not simple. Now we'll try another polling question here. Question is, what resources do you have available in your health system to deal with excess product? You can check all that apply. Do you have highly accurate inventory data, advanced analytics? Do you have in-network logistics and, frankly, reverse logistics? Do you have partners who will buy excess or take donations, or none of the above? So again, what resources do you have available to help you deal with excess product? Do you have highly accurate inventory data? Do you have advanced analytics capabilities in-house? Do you have in-network logistics and reverse logistics? And do you have partners who will buy your excess or receive donations? Or do you have none of these resources to help you? We'll give it a few seconds for a few more respondents. Okay, we have about 50 respondents, so let's take a look at the results. So it's an interesting smattering of results across the board. For some of you, I feel bad. For 30+% of you, you have none of those resources. And I'll tell you, don't feel terrible. You're not alone. A lot of folks have a challenge with all of these resources in their availability, and in many cases, while they may have one, they don't have the other. And solving the reallocation challenge really requires all of these resources to be available to you, and so that's one of the challenges that the Steward team had to work with. Now, Michael, can you give us a little insight into how Steward evaluated the different options for preserving value between move, sell, and donate?
Absolutely. So, the first thing is look, we've already spent the $24 million. So it would be nice to be able to use it in our family of hospitals because at the end of the day, that saves the system $24 million of incremental next spend. And so as we thought about it, we decided to do a couple of things. One is that we stood up a distribution center where all the inventory was moved into, and as Carl mentioned, there was 365,000 items. I think it was 2 million individual pieces that were actually moved, 10,000 totes. And so how do you stand that facility up to receive all of that supply and do it in a timely fashion so that you can share back out to the sister facility what's available to them? Because what you really want to do is you want to change the way they're going to order the next item. Your ERP is set up that they requisition, and it's set up to know what the number one primary vendor is and go out and buy it. Well, we need to intercept that signal so that we can actually divert the attention to the self-distribution point and make sure that we have the first opportunity to ship that item first before we go out and procure. So that was really important. Second is this notion of help. Even if you can think through the problem, having an extra set of hands and eyes on the analysis, eyes on the data, hands on moving the totes is really important. At Steward, we run a really lean supply chain at the hospitals, with quite frankly as few people as possible. And so you don't have extra bodies to pull items off shelves and fill totes and shrink wrap and inventory and then ship out. They're really designed to receive whatever comes in today, get it out as quickly as possible to the departments, and then, quite frankly, restock some perpetual inventory sites and et cetera. So there was a lot of kind of work up front that had to happen in order for us to be in a position to do it. But the goal, quite frankly, was to move as much as possible. The sales stuff became obvious. When you're sitting there looking at 3 years of inventory position, where are you going to keep it? Are you really going to keep it on the shelf for 3 years? Is it going to expire within that time window or not? And quite frankly, do you really want the carrying cost of capital associated with an item that's going to sit for 3 years before it'll potentially be consumed? And so that led us to more readily identify that pot of what should be potentially sold on the open market. And then the donate is quite frankly, very easy. It's those things that you've converted out of and you're never going to use because no one in the system has a need for it. In some cases, maybe somebody thought they had a great bulk opportunity, and they did at the time, but 2-3 years later, it's no longer a great opportunity because you're not consuming the inventory. And at the end of the day, it still comes down to not only the net benefit of the next transaction, but it's also the carrying cost of capital. And so it's very easy to say, $24 million, but what's your carrying cost of capital? And even if you just say it's a neat 10%, that's $2.4 million you're going to spend every year financing inventory that's just going to continue to sit on the shelf with no burn rate in sight. And so that was really some of the thinking that we did as we thought through this particular problem and thought about how to reallocate across the 3 buckets.
Thank you. Now, as Michael mentioned, the project requires a lot of lift, and in order to get the project executed, Z5 brought resources to all of those components that Michael mentioned: the planning, the analysis, the actual physical movement, and even standing up the third-party logistics warehouse, which Z5 manages today in Youngstown, Ohio. So we bring those pieces. Michael, what would you say is the most difficult part of getting a project like this to work?
Yeah, the first is to break your bad habits because, remember we talked about hoarding before, and it's a natural tendency as human beings to do that, especially if you've had difficulty procuring something in the past. You remember that scar of when somebody needed something and it just wasn't there, and so there's a proclivity to do that. So sitting down with each of the departments and going through what we considered to be excess inventory, and quite frankly, in some instances, convincing them that they in fact had, if you will, had acted not in bad faith but in bad behavior, and they didn't do it intentionally. It's just kind of a matter of an outcome, and so working your way and navigating the politics of that was very delicate and something that we enjoyed doing, quite frankly. Because what was interesting is as the lessons kind of seeped in and started catching on, because if you notice, if you add up some of the numbers in the different slides, in one case it's 24 million. That was our starting point. I think we actually got to somewhere around 28 million of what we actually took out of the facilities, and it's because as people started to trust that process, they started to say, hey, what about this other thing, or what about this thing here, or what about? And so all of a sudden you had kind of a groundswell approach where people were buying into the program of saying, hey, this is an opportunity to clear our shelves, and at the same time give us an opportunity to acquire things that have already been paid for, and therefore at the end of the day saving Steward Healthcare money. And all of those things are really important, quite frankly, whether you're a not-for-profit or a for-profit. And so, leveraging Z5 and their experiences in analyzing the data, and then, quite frankly, again, we're not built for shipping product out, and so there was no way 365,000 SKUs could go out of all of our facilities just because somebody wanted it. We didn't have the staffing to support that, and so knowing that Z5 was able to help us with the bodies that were required to affect the changes was really important to the decision that we made to do this project.
Thank you. So as Michael mentioned, each facility was prepared for the move, and the preparation was done by what we called scouts. And the scout, in my mind, is somewhat of a change manager, educator, salesperson almost, to go out and work with each facility and really dig down into the leadership team at the facility. So it's not just at kind of the materials manager or supply chain level, but in many cases, that behavior change and that education has to happen at the kind of departmental level, at the person who's deciding what to order and what to stock in that, SPD lab or in that EP lab or in that operating room. And so the scouting effort really focused on those SKUs that had been identified by the analytics, but it also worked to try and help people to understand the value of inventory, the cost of having it sit on the shelf, and just that there are options for liquidating it. As Michael mentioned, in many cases, folks in the field, they realized they had certain products that they were no longer using. They just maybe didn't know how to get value out of that product in their own local facility. And so we had coined a phrase, and that was to act as one steward and to attempt to always think bigger than my local department or my local hospital and look for ways to benefit Steward as an organization. And as that kind of behavior took hold, we started to see better results. And those results improved through every single facility as we moved through the facilities. Michael, can you give us a little sense of how that rolled out, and then also how corporate supply chain kind of monitored that process, as well as the finance and chief financial officers at Steward?
Yeah, you bring up a really important point, Carl, is this is not just a supply chain event. It's really a Steward event. You talk about the people who are requisitioning in each of the facilities and all the different departments that are impacted. You're talking about local CFOs and regional CFOs and presidents and regional presidents. And then, quite frankly, at the corporate, side of the house, you're impacting finance, and because they have to move inventories around, right? You take something out of one location, it's no longer in their possession, so it really shouldn't sit on their balance sheet. And so making accrual so that things can move appropriately, and then when that item ultimately lands someplace else, how do you manage that and book it correctly in the financial statements? And so we had to partner with a lot of different parts of the organization to do all of that. And fortunately at Steward, we have a pretty collaborative group of folks that are always looking to do what's really right for Steward to begin with. And so maybe it's not convenient, or maybe it's not expedient, but at the end of the day, people buy into the notion of, if we do this correctly, we can actually help the finances of Steward, and that's really important to do for any number of reasons, including delivering quality patient care, which is the number one reason that we do all of this to begin with. Like any project, we started out with a pilot, if you will, a couple facilities. Now remember, Steward grew up through acquisition, and so each company, as we brought those acquisitions on, we tried to teach them the Steward way, but you don't just do that at a point in time. It takes a long period of time to change the culture and the nuances. And, so some facilities would be very receptive to a corporate sponsored program, and others were going to fight you tooth and nail. And so making sure that you were aware of those kinds of dilemmas as you went through it was extremely important. And so, in this case, we picked out one in the West and one in the East, but we picked out sites that we knew would be favorable to work with us, who would be, interested in a positive outcome. and really kind of help us test the theories that we were applying, making sure that they worked. And then like any other project, you do 4, then you do 8, and 16, and then all of a sudden you've got the entire system done over a 6-month period of time. And so that was really the approach that we used for removing the excess inventory. Now, the corollary of that, though, is you have to get the product back into the hospitals, and just like change management of anything else, you still now have to change the way people think about inventory and where's that first location they go to look for something. And the first location may be the department, but when it's time to requisition, the first place they need to requisition from is from our north side Youngstown facility, because that's where the benefit from Steward comes from for this particular program. And so giving them the right tools and the right political support to make those kinds of changes was extremely important to the whole program as well. And then the final thing that I'll add that became really relevant is how do you prevent excess from creeping back? Because if you're going to take $24 million out and you say you've worked on this notion of hoarding, or we're going to do conversions better, or whatever it is, how do you really monitor it and make sure? And so associated with this was a complete re-leveling of all of our min-maxes across the entire organization as well by facility, which, as you all know, means relabeling and et cetera, and changing ERP systems. And so there's an awful lot of work that goes into this behind the scenes that no one even recognizes as part of the project, but they are extremely important if you're going to control it and really measure it going forward.
Thank you very much. And you'll notice, if you look at the timeline, that we also had just a small stroke of luck in that we finished this project in March of 2020. And so there was a lot of field work happening right up until the crack of the pandemic. And we feel lucky to have gotten the last few facilities in right before everything went focused back on pandemic and sustainability throughout the last 12 months. So we were lucky to start when we did, and lucky to get the project, at least the first big part of the project, completed by March of 2020. Now, as Michael mentioned, as we moved through the facilities, we gained steam, and we also improved our process, and more and more folks across various Steward departments got involved, and that really helped to push the result higher and higher. And so we would do the scouting reports, submit those back to the corporate supply chain team. The regional supply chain VPs would sign off, Michael would sign off, and even the regional CFOs would sign off to make sure that their local facilities were actively participating in the process and reviewing their products in a way that was contributing to the goal we all sought. And so that really resulted in a very positive outcome. So out of the $24 million that we initially identified, Michael, can you share with the team the ultimate results that we experienced?
Yeah, happy to do that. So, as noted, we moved around $17 million to Youngstown. We have labeled to resell about $3 million, and then we donated right around $3 million as well. But remember, those are the hard dollars that, quite frankly, you're moving around on the balance sheets as you talk about inventory, and then your P&L as you expense it. The hidden cost of all of this is that carrying cost of capital, and don't minimize, because at the end of the day, that has a direct financial impact just as important as not spending the next dollar on the next widget as well. So at the end of the day, it probably saved each of our facilities about $500,000. Now, it wasn't it's a bell curve, so I can tell you that there were a few around the average, and then you got some tails. One of the facilities, I think, moved about $2.5 million of inventory, and so there was an example of a facility that, quite frankly, was out of control with inventory management, and it gave us a chance to reset how they were thinking about inventory and the way they were going to manage it going forward. And I'd like to think that going forward we'll be in a better position to help them not make the same kinds of mistakes they made previously by over ordering. In this case, they were really guilty of bulk buying. So we'll prevent that from happening going forward as well.
And Michael, tell us a little bit about how you garnered kind of C-suite support for the project prior to launching it, and then how did they stay in tune with the project as it progressed?
Yeah, so at the end of the day, any project has got to give something to each of the stakeholders, and so The chief financial officer was really interested in the carrying cost of capital concept and what it really meant to his balance sheets and the P&Ls for each of the facilities, as well as the roll-up to Steward. The chief operating officer, who I report into, was very, very cost conscious about how we could save spending on the next widget, but at the same time, the idea wasn't necessarily to let it drop to the bottom line. It was, how do you leverage your money more wisely so that you can make better investments, and maybe even more investments in this case? Because every dollar that didn't go to inventory, we now could spend it on a capital project or some other important need within the four walls. And we all know there are many, many, many things that we would like to spend money on all the time, and so having extra money on an annual basis isn't a bad thing if it allows you then the opportunity to go out and spend it wisely on some other additional things. So for the executive leadership, was really key to make sure that each one of them kind of, if you will, got something out of the project. At the local level, the arguments are similar but different. They've all walked into nursing storerooms and department storerooms and ORs where they're bursting at the seams, and so talking to them about having a cleaner environment and one that's more readily available to find the things that you're looking for was really kind of pretty important to do to them, and talking at the local level about working on min-maxes together and redefining the way we were going to think about inventory and order points was extremely important, and to do it one by one so each one of them felt like they had a voice in the process as well as the outcomes for their facility was extremely important. And at Steward, we have a regional layer on top of it as well, and again, they're kind of a cross-section between the two groups. And so, again, the most important fundamental thing to me in any project that you do is making sure that the key stakeholders, that each one of them gets something from the project that's meaningful to what it is that they're trying to accomplish, and that's how we actually cast this across the organization to get the widespread support for it.
Michael, from my perspective, it was amazing to watch the leadership team of the regionals, the local facilities, and the corporate supply chain group all sort of come together toward one goal as the project progressed. And really, as I mentioned earlier, our performance and our results got better and better and better as the project went along. And to me, that was an indication that as a group, we were all starting to kind of embrace the concept and really bring it into our local facility in a way that would maximize the result. Now, we've completed round one. I want to ask you, could we have done better? And if so, how, and what are some of the challenges to making this work?
You always can do better. There's always lessons learned. And so, I think we did a really, really good job of executing phase one, which is how do you remove from the facilities what we call an excess, describing it and making people truly understand what was needed in order to, tote it up and ship it out and get it delivered and back on the shelf at a new distribution point. Handled that, I think, relatively flawlessly. And, from every facility that we did, we took a moment to, talk about lessons learned. And so we got better and better at it as we went along. And by the way, that allowed us to circle back because there were some facilities that as they kind of came to understand the program more and more said, hey, maybe we weren't as aggressive as we could have been on round one, and so maybe we'd like you guys to come back, and there's a round two here that we should do as well. So that told me that we had done a really good job explaining the phase one of the project. The part that we probably didn't spend as much time on, and in retrospect probably should have, but I'm going to say hampered somewhat by COVID as well. We all know what we've lived through over the last 12 months, was the how do you get people to change their ordering habits? When a requisitioner gets very, whether it's a template that they're using or just from rote memory, they're very comfortable doing the same thing over and over and over again. They've got it memorized, and so it's very easy for them to do it that way. Now, all of a sudden, you're introducing a new way, a new order point, a new inventory location to at least consider. And so, how do you really create the tools to support that? And I think as we've gone along in the project, we've gotten better of categorizing and breaking it down more succinctly, so that people aren't looking through 365,000 items. They can actually get to a product category and then, more easily search for the things that they're looking for. And because we're in multiple ERPs across 10 states, we didn't have the ability to do it all in one system, which also hampers the way you think about that phase two of the project. And we're working on things now that will solve that going forward. But foremost, and for us, will be that we're going to a new version of the ERP system across the entire system. So having one inventory ordering point going forward will change the dynamics of that considerably as well. But I think that really kind of thinking through the entire timeline of the project from start to finish, and not just how you're going to get everything out of the facilities, but how you're going to actually, if you will, get the things back into the facilities, both of those are equally important questions to ask and to have thought through and have answers for.
Right, and as Michael mentioned earlier, Steward was built through acquisition, and so we were dealing with, at a minimum, 2 different ERP systems. The East was primarily using Meditech, and the West was primarily using Lawson. And some of the Meditech had actually converted from a previous version of Meditech as well. So there were a lot of moving parts relative to data, analytics, and processes that had to be standardized in order to get everyone to participate in a way that would drive the result we were after. Those are some of the challenges that Steward dealt with. Let's ask the audience a little bit about what are the biggest obstacles that you think you might have in reallocating your excess inventory. So largest obstacle, is it a lack of analytics, a lack of logistics and infrastructure, a lack of internal cooperation, lack of time and other free resources? So again, we'll kick this back out to the audience. What do you believe to be your biggest obstacle to reallocating your excess inventory? A lack of analytics, a lack of logistics and infrastructure, a lack of internal cooperation, or a lack of time and other free resources? Give it a couple seconds for the results to come together. Okay, we've got about 50 respondents, so we'll jump over to the results and take a look. So pretty evenly distributed across, almost perfectly evenly distributed across the 4 different factors. So all of those key factors are challenges for most of you out there in the field, and we recognize that. And at Z5, our goal is to help you through that, whether you need more analytics or you need more time and resources. As Michael mentioned, his health system was not staffed at a level that could just all of a sudden, work reverse logistics on 25% of their inventory value. So in many cases, it was Z5 arms and legs that were performing that activity with some minimal guidance from the local health system staff. So that's our objective, is to provide that kind of support, resource, and leadership to your teams as you embark on this kind of a process. So what does it take to do reallocation right the first time? We've kind of identified a few really critical steps, and we'll talk for just a minute on each one because I think they're all important. The first is that you really need to be able to analyze your data. And I think at the very beginning of that, you need to have accurate inventory data. So one thing that Michael mentioned early on is that they take a house-wide physical inventory once annually. And that data is really the foundation for this effort. So it's, before I can even talk about what might be excess or obsolete, I have to know everything I have, exactly where it resides in the facility, and then I can begin to analyze what of that product is at risk. And I think for many health systems, this is a challenge in part because they have the most accurate inventory data about the things that are maybe managed most closely by the supply chain. So central supply or a warehouse in the hospital. And the further you get away from that central supply chain and frankly get closer to the patient, the less accurate data we have about inventory. So that annual inventory process provides that foundation that you can then do analytics on. And the second challenge around analytics is just the volume of data that you have to deal with. So there are lines and lines and lines and lines of purchase order data that have to be evaluated and run across against this underlying inventory data. And for a lot of folks, that is a very big challenge, just even computing power to handle that. And so that's a definite challenge, and it is a critical element to success. If you don't have a good data analysis at the beginning of the project, you will get challenges from people as you move along. Now, Michael, can you talk about that collaborative culture?
Yeah, I've commented on a little bit already, but I think it's one of the most important things for our Steward supply chain. We do not make decisions in isolation. We have a very robust value analysis team. We are regionally engaged. I've got directors who are meeting regularly with each of the hospital administrative teams as well as the supply chain teams. We're making sure that we have solid relationships in the ORs, and so we can have hard conversations about various topics. And if you really work on doing that correctly, you're building trust along the way. And so in this case, we asked people to trust us, that we had their best interests at heart. That while this was a corporate-led initiative that was going to have some financial benefits to Steward as a whole, that again, we were going to make sure that every stakeholder was going to get something out of the program. And that's really, at the end of the day, what you need to do in order to create that collaboration. It can't be one-sided. It really has to be everyone gets a win. And we were able to kind of think through collectively how to do that for each facility, so they felt like by donating and contributing time and effort to this important project, that they were going to get something out of it that was not just financially related. I mean, that was the driver, from a corporate supply chain perspective, might even been the driver from a finance perspective. But when you're in the hospital and you're thinking about patient outcomes and patient care, that's not always the first thing that comes to mind. And so making sure that we're really tied to those things is really what was really beneficial from a collaborative culture and perspective. Now, one of the things that, helps us in that endeavor quite a bit is that we are physician-owned. And so we have a very interested group of doctors, if you will, who, if you go to them with reasoned arguments and present the facts, we get really solid buy-in all the time. And so that's an important distinction. But again, you earn that through trust and by demonstrating value every step of the way. They might trust you the first time, but if you fail them, they're going to look at you very skeptically the second. And so for us, it was always about making sure that we always were delivering wins in the time frame that we said that we were going to, and making sure that everybody participated in those wins.
And I think in this particular case, especially considering the volume of product that was being moved and the mechanism that we had selected for putting it back into the facilities, we needed to set up a fairly robust logistics system, or in some might call it reverse logistics. So we had to actually back that product out of its clinical storage locations. We had to do that in a way that preserved sterility in some cases, that preserved product packaging, that preserve the product so that it could be reused in another facility, and know that the same quality of product was arriving at the end destination facility as when it had arrived at the original facility. So that logistics system, as we mentioned, included things like totes, included a central warehouse in Youngstown, Ohio, where we were fortunate enough that Steward had a facility that we could use to set up and manage all of these SKUs while they were waiting to be reordered back into the new facility. So that logistics system was a key backbone of the project and really allowed us to execute the project in a flawless way. And then, of course, last but not least, you have to get energy and momentum around the concept of reallocation. And I will say, from Z5's perspective, I'm going to give Michael some props here. He was a fearless leader throughout this project. I can assure you there were times when some of his people thought, maybe we shouldn't be doing this. This is a lot of work. Are we getting enough value, et cetera, et cetera. And Michael was very energetic, stayed true to the goal, and led the team through the process, and it really resulted in a great outcome. And the last thing that we put on there is repeat. And we talked about this a little bit earlier, like, can we just do it once and then be done? That would be a really nice thing. But I ask you to think about the last time you cleaned out your garage at home and you had everything neat and tidy, and especially if you have kids, I think you turn your back and you come back out into the garage a month or two later and everything is full again and it's all spread out all over the place. So I think the lucky health system might get by doing it once, but most health systems need to really embrace a culture of continuing to just examine the products they have on shelf, think about whether they're really being used locally, and repeat the reallocation. And at Steward, we've seen this really take hold, and I think Michael alluded to it. Even as much as a year later, some of the sites are now kind of re-engaging after their most recent inventory in the fall. They're reanalyzing their data, again, with Z5's help, and they're turning product that can be used either by the health system or sold in the third-party market or possibly donated. And so the project has a very long-lasting tail that will bring benefits far beyond even this first big lift. So that's the end of our prepared remarks. We want to open the webinar to Q&A. And at this time, I'll turn it back over to Molly to lead the Q&A session.
Perfect. Thanks, Carl, and thanks, Michael, for that excellent presentation. Attendees, like Carl said, we will now begin today's question and answer session. If you haven't already, you can submit any questions you have by typing them into the Q&A box that you see on your webinar console. So let's get started with the first question. This one comes from an attendee. It goes back to, Carl, when we were discussing the what causes supplies to build up. This attendee would like to know, with a change of contract conversions, why would a facility not simply use what's still on hand before using any new product? Carl, can I start with your thoughts to this question, and then we'll check in with Michael if there's anything he would like to add?
Sure. I think in many cases, Molly, that is the goal. The goal is always, let's burn down our existing product before we start building up our new product. The reality is certain things sometimes cause a change in that. So the first one I think that's important is whenever we make a conversion, there's usually a process where we're trying to encourage surgeons, doctors, practitioners to get on board with that change and to embrace the newly contracted product. And oftentimes that works best if you simply just make the change 100% and the old product is no longer available to them. If the old product kind of lingers, then there's this feeling that, well, if I kind of prefer that old non-contracted product, I can just kind of keep getting it. I'll just keep asking for it in the future. And so sometimes the best way some health systems have seen to make conversions is to make kind of a wholesale cutover. And through the reallocation process, in Steward's case, for example, you could make that wholesale cutover at 30 out of the 40 facilities and leave a few facilities to cut over maybe a few months later, and they might be able to consume all the remaining product on the old product. So, Michael, can you talk a little bit about your perspective on conversions and kind of how that's handled at Steward?
Yeah, I think that it's an important question to ask, and there's any number of reasons why you need to do a hard and fast conversion date. As Carl described, as clinicians, creatures of habits, they'll continue to use what they're most familiar with or what they prefer, even if the clinical outcomes of A versus B are exactly the same, and you can demonstrate that. It doesn't mean that conversion can happen. The second part is that you may have just a lot of stuff sitting on the shelf. I mean, are you really going to wait 2 or 3 years potentially to realize value because you at the end of the day bought too much? But it's also, there's times, how many times have you bought a case of something where it's a pack of 10 and you really only need 3 of them? And so you're going to have 7 of them sitting there for a long period of time anyway. And so there's a lot of different reasons why we have inventory that sits on the shelf. And what I would argue is there's a balance, of course, on any conversion to say how long should the conversion last, what's the value of it versus at the point in time when you're going to erode either the savings opportunity or miss out on it completely. And so those are all reasons to do the hard and fast cutover in advance of potentially having burned down the inventory on hand. And as Carl suggested, in our case, we're able to kind of logically think through conversions. We just went through a massive IV pump and solutions conversion that took better part of a year to do across all the hospitals, and we were able to very logically think through, well, if I move all of this inventory over to this hospital and I wait 6 months to move them, then I have an opportunity to consume. And so we did a lot of those kinds of things. And so I think for every SKU you have to think it through thoughtfully how it is that you're going to handle it. Some things you can cut over immediately. Some things take a little bit longer time to do. But at the end of the day, it really comes down to what's the benefit of hanging on to something one more extra day versus not. And I think that's the trade-off analysis that has to be performed.
Terrific. Thank you both for shedding more light on that question. This next question comes from an attendee who would like to know, how do individual sites have visibility to excess inventory identified as available to move?
So at the individual site level, Molly, there were kind of two key components that they had to work through. The first was they had to review with the scouts every SKU that was identified as possibly being excess. So the way that really worked is Z5's analytics kind of pointed out all of those SKUs, and then those would be published in the Z5 online platform and or in spreadsheets in some cases, and the local staff would work through decisions on those platforms. And with the scouts, we called that decision keep or remove. And so certainly in some cases, there would be product that would get identified as excess, but it needed to stay for that emergency case, or perhaps there was some specific clinical use of that product that had maybe just not happened for a certain period of time, or there was some likely thing coming up that the local clinical staff knew that product needed to be kept. And so they would make a decision around keep or remove. And then in some cases, as Michael indicated, they might have bought a box of 10, but they really only need to keep 2 on the shelf. So they would keep a partial point. So that was all done through the Z5 platform and together with the kind of Z5 scouts leading that. Now, the second part of that question is, now after everything's been removed and we now have this pretty good size warehouse in Youngstown, Ohio, with all of this product available essentially for free back to the various hospitals and facilities, how do they know what's there that they use? And so in a similar fashion, Z5 prepares a weekly report that goes out to every local materials leader that shows all the products that reside in the Youngstown, Ohio facility that we see purchase activity at the local hospital level for it. So that allows them to look at a subset of everything that's there, just the stuff that's relevant to them, and then they can order that product from that facility in Youngstown. And as Michael mentioned, that's been a challenging part of the project. And I'm happy to say that now we see an order from every facility every week, but that certainly wasn't the way it started out in week 1. That's taken some learning. So, Michael, any thoughts on that process and other things around it?
No, I think at the end of the day, you build an awful lot of goodwill with the locations in the phase 1 part of it, which is, I call it horse trading. You know, it's like we went in there with a position, but we were open to the arguments that the locations were going to make as to why our analysis wasn't the correct one and why the outcome should be different. And so we talked openly about what those decision points were and made it very much, again, about the end user rather than just this corporate initiative that was going to dictate the way things were. We still had goals in mind, and we still tried to enforce those goals. But, you know, we often said, all right, well, if we leave this behind, what else is there on the shelf that we're not thinking about or that you're thinking about that should be on the list? And so that collaboration of back and forth builds up an awful lot of goodwill, which then allows you then to leverage the second part of the program, which is how do you now get people to start considering what's sitting on the shelf and that they should order that as a starting point as well, even when it's inconvenient to do so. So I think that collaboration point is really the important one when it comes to how you really make this thing kind of work, if you will.
Terrific. So we talked about the moving component of the reallocation methodology. There were several questions that came in about the selling portion. So let me review 3 of them for the sake of time. The first question is, how did you facilitate the selling of excess inventory? The second question, are you selling at a discounted rate or market rate for inventory excess? And then third, who bears responsibility for any contamination issues related to sold goods that are supposed to be sterile?
Great. I'll
Carl,
take
can I
this
start with
Michael.
you? Okay.
Yep. Thanks, Molly. So selling is a key part of the overall reallocation process. Clearly, the larger the health system, the more ability you have to use the move component. But in a smaller health system, selling your excess might be your only avenue to dispose of it and get some value back. So there are a couple key tenets that Z5 believes are important in doing this in a structured and safe way. So the first is that we immediately remove all of the product from the hosting facility. And we move it to our warehouse in Austin, Texas. And the reason for that is many, but I'll give a couple. So the first is quality. We want to put every product that comes out of a facility through a quality review. We want to check the expiration date. We want to make sure it's in original packaging. We want to check the quality of that packaging. Has it been tampered or possibly damaged during any transportation, et cetera? So there are a number of quality checks in our standard process that we go through as we intake a product from a facility, so that when we resell that product out to one of our customers, we can ensure that that product has the same quality as when it came from the original manufacturer. So that's one reason we bring it all in-house. The second is that when a new customer orders that product, they expect the same kind of customer service that they get from their normal distributor. So they want an order confirmation. They want to get a shipping notification. They want the product to be boxed up and shipped in appropriate packaging on appropriate time frames and shipped to them on a timely basis. So by bringing all of that product into the Z5 warehouse, we can ensure that every customer who buys that product is getting the same type of quality customer service that you would get from Cardinal, Medline, Owens & Minor, any manufacturer in the industry. And so that's the second major reason for bringing it in. And then there was a question about pricing and how that product is liquidated. So one of the unique things that Z5 does is we partner with our reallocation clients. And we do sell the product at a discount in the marketplace. That's typically the only way it's going to get unloaded, is that some other buyer has to have some incentive to kind of work with a slightly different supply chain than their normal supply chain. So we'll sell it at anywhere from a 20, 25% to maybe as much as a 30 or 40, even 50% discount off of the normal pricing in the industry. And then we share back with Steward on a preset agreement a percentage of those sales proceeds. So Steward is able to share in the upside of the job that we do in liquidating that product. And that's kind of how the sell function works.
Terrific. Thank you so much, Carl. Let's see. I think we have one question, about 1 minute left to address it. So any thoughts you can share in the time we have is appreciated. And that question is, what are your suggestions for reducing inventory when one works in a critical access hospital that's not part of a system that can share products?
Yeah, I think your challenge is unique and particularly difficult, and I applaud you for the effort. It's much more difficult when you're not part of a system and you can't share across other health systems. And I think at Z5, our goal is to kind of bring a network to you. So through our existing customer network, can we bring to you a place where you might be able to, one, liquidate some of your excess product at a discount? You're not going to get full price back for it, but you'll get something. And then could you turn around and possibly acquire some discounted product that perhaps Steward had put into the system? So we get kind of what I call a network effect. So can we all benefit by participating as part of a bigger whole? And Steward is participating as part of a bigger whole, both within their network, that's the move component, and outside of their network in the sell component. And then lastly, buying discounted product back. So it might be product that critical access network put in. It might be product that another critical access network hospital donated because they don't use it anymore. So what we're trying to build is a platform for all hospitals in the country to try to eliminate as much of that excess product as possible and make sure that we're getting the most value for every dollar we spend in the supply chain.
Thanks, Carl. And that is all the time we have for today. I want to thank our attendees for their great questions and responding to the poll questions throughout today's webinar. Also want to thank you, Michael and Carl, for an excellent presentation, and Z5 Inventory for sponsoring today's webinar. Thank you for joining us today, and we hope you have a wonderful afternoon. Thank you.